The PURPOSE trials revealed a near elimination of new HIV infections in people receiving twice-yearly Lenacapavir injections for HIV prevention. The discovery of this highly efficacious option for HIV pre-exposure prophylaxis that requires relatively infrequent administration has called into question the continued importance of developing an HIV vaccine. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Lauren Jatt, an infectious diseases fellow at the University of Washington. Dr. Jatt has co-authored a perspective article about the tools needed for ending the HIV epidemic. Dr. Jatt, could you start by summarizing the design and the findings of the PURPOSE trials?
PURPOSE 1 and PURPOSE 2, which are the two PURPOSE trials that have been published so far, there are additional ones that are underway, were really designed to evaluate the effectiveness of a once every 6-month subcutaneous shot of a long-acting drug called Lenacapavir to see if it would prevent HIV acquisition. The PURPOSE 1 trial was done in cisgender women in sub-Saharan Africa, and the PURPOSE 2 trial was among gender-diverse people all over the world. Patients either got the Lenacapavir shot or they were randomized to a different type of HIV prevention, including taking tenofovir pills.
So before those findings were reported, what options existed for PrEP, and why was it considered important to find tools that offered a longer duration of protection?
There's lots of different forms of PrEP. Probably the most well-known type of PrEP is a daily pill of tenofovir. But people also can practice other types of HIV prevention, including condom use. In some places, circumcision is recommended. There's really an entire grab bag of PrEP tools. But a lot of these tools have downsides. I mean, in particular with PrEP, it's something that for many people you have to engage with daily, or you can take on-demand PrEP, which is PrEP before and after sex. But these particular tools do require very stringent adherence, particularly for women, whereas the once every 6-month Lenacapavir shot provided a longer duration of protection because you just needed one shot to protect you for 6 months.
So, in fact, you say in your perspective article that twice-yearly Lenacapavir shares important features with an ideal HIV vaccine. So what qualities of the drug make it an important tool for HIV prevention?
So I think the things that were similar about Lenacapavir and a potential HIV vaccine that got me interested in asking this question of whether or not Lenacapavir could potentially replace an HIV vaccine is that, first of all, it's safe. It's also very efficacious. It was 96 to 100% efficacious in these trials. It's also thermostable, so it's easy to give. And then most importantly, one shot can protect you for 6 months, which is probably a similar duration of protection to some of our shorter acting vaccines like influenza vaccines or COVID vaccines.
So despite all of that, what would be the potential limitations of an HIV prevention strategy that relied exclusively on something like Lenacapavir?
Even though Lenacapavir shares a few attributes with the potential HIV vaccine, I think there are quite a few downsides to the Lenacapavir-only PrEP strategy. So although it does provide 6 months of duration, this duration of protection in the grand scheme of most vaccines is actually very short. So many of our licensed vaccines protect for many years, if not give lifelong immunity. For example, the measles vaccine, the hepatitis B vaccine. So the idea would be that if you have only 6 months of protection, that requires continued and constant engagement with a healthcare system. This actually is hugely problematic for people who live in areas with any unstable access to healthcare. For example, if there's war, economic collapse, environmental disaster. Additionally, the short duration of protection means that the individual must continue to identify as needing PrEP throughout the period that they're on it. And so if at any point they think that they're no longer at risk of HIV acquisition and they decide to stop PrEP, they're then vulnerable to potentially acquiring HIV, which is something we have seen in studies. Another huge difference between PrEP and a potential HIV vaccine is that PrEP is a targeted intervention, whereas vaccines are generally recommended universally. The problem with targeted interventions is that they miss people who don't meet criteria. So, for example, about 40% of people every year in Eastern and Southern Africa that acquire HIV don't actually meet PrEP criteria. So this would be a huge number of new HIV acquisitions that would continue to happen if we only used a PrEP strategy. Additionally, it's much easier when you have a targeted intervention to be overlooked by your provider due to their bias. They might not realize that you're in a higher seroincidence group and more likely to acquire HIV, and they might not offer you PrEP or you might not ask for it. And then finally, targeted interventions are unfortunately much more susceptible to stigma than universal interventions. And so the nice thing about universal interventions is that it doesn't single anyone out as being different and therefore needing something. And stigma has been a huge issue with PrEP in many areas of the world. Additionally, the other problem with lenacapavir is that since it's a small molecule drug, it's susceptible to both drug-drug interactions as well as drug resistance. So in the PURPOSE trials, they actually excluded people who were on a wide range of medications, including things like antimicrobials, anticonvulsants, systemic glucocorticoids. So these people wouldn't be able to get lenacapavir unless specific studies were done to show that lenacapavir is safe in those populations. And then finally, drug resistance was also an issue in the PURPOSE 2 trial. I think this is still a huge question for using lenacapavir for PrEP, but there were 2 cases of HIV acquisition that showed an N74D capsid inhibitor resistance mutation. And I think that any form of widespread resistance would be an existential threat to a PrEP program that relied exclusively on lenacapavir. And then I'll just add as well, we don't currently have infrastructure for the massive scale up of PrEP around the world. Implementing the massive scale up of PrEP would require training on injections, testing strategies, new clinics. These are all things that are going to take really intense investment. In contrast, we do have, although they're not perfect, we do have routine immunization systems in place in pretty much every single country around the world already. So it's easier to conceive that an HIV vaccine could be put into those systems and rolled out.
And then back to vaccines, what's the current state of research? How close are we to actually having something that could be implemented?
Currently, we're in phase 1 and phase 2 development of a variety of candidates. There was some very exciting new trials that were published within the last 2 years that showed that there are candidates that can actually produce broadly neutralizing antibodies. And so I think that these 2 papers, one was published in Cell and one was published in Science, have really given renewed excitement to the field in thinking that we are increasingly close to an effective HIV vaccine.
So finally, you argue in your article that only an approach that combines injectable PrEP and a vaccine will end the HIV epidemic. What would that kind of combined approach look like?
One thing that my collaborators and I all really strongly feel is that choice is also a really important part of PrEP, and knowing that one size doesn't always fit all. I think depending on the environment that you're working in, the public health system as well as the individual, you really want to be able to tailor your approach. So I think in some areas, a vaccine is going to make a lot more sense. And in other specific groups, long-acting PrEP would still potentially be a really important part of HIV prevention.
Thank you, Dr. Jatt.